I just want to give you the full spectrum of valley fever the best I can. And so we have a lot of slides from diagnosis, treatment, pathology, transmission, and we'll go through as much as possible. I'd like to thank the staff here at the Arizona Osteopathic Medical Association for inviting me to talk to this subject that has grown near and dear to me. I've learned to have a passion for this illness. I moved here from Michigan in 1997, and right out of the gate, I was amazed how many cases of community-acquired pneumonia, pulmonary nodules, pulmonary cavities, lung masses were not cancer, were not bacterial. It was this strange fungus called coccidiomycosis. And to that point, I was also somewhat surprised how many people who've lived here for decades really didn't fully understand the disease, and even the medical professionals were ordering the valley fever test when patients had pneumonia. So my goal today is to help raise awareness and educate you on the signs, symptoms, diagnosis of valley fever, discuss some of the pitfalls in diagnosing valley fever, some of the problems with the blood tests and the side effects of azole antifungal therapy. I'd also like to discuss the new skin test, Spherosol. Many of you may know there used to be a skin test, and it was out of manufacturing for about 20 years. And a couple of years ago, it was remanufactured and brought back to life, thankfully. One other thing, any patient you may see that has pneumonia in Arizona, you have to consider valley fever. One study showed that 29% of community-acquired pneumonias was due to valley fever. So it's often not even thought of. Patients get 1, 2, 3 plus antibiotics before somebody decides to do the test. We'll say in recent years, I think it's much better, and I've seen a lot of people ordering the test right away and treating empirically, but still it's missed quite a bit. About 10 years ago, the governor did a proclamation for valley fever. It's called Valley Fever Awareness Week. It occurs every November. It's a year that spotlights attention on this endemic disease of ours. And it states in there that valley fever basically tripled in the last decade, that it has a significant impact on the citizens and the hospital systems here in Arizona. And you can Google this and see what it says. But one of the interesting things, too, is University of Arizona Valley Fever Center of Excellence. They do a lot of medical studies for valley fever. They do a lot of lectures during this week also. And you can see that on their website, the Valley Fever Center for Excellence. So let's talk about what is valley fever. And it's a layman's term for the fungus coccidiomycosis. It's a dimorphic fungus in the desert soil. It has two phases, a saprophytic, where it exists on dead, decaying material, and then once inhaled, it changes shape, and it has a parasitic cycle. It's somewhere between a few inches below the soil to up to 12 inches. Class of fungus is Ascomycetes, and there are two species that have been identified. Imitis, which is the original cocci species, and Posidacea was identified as a separate genetic makeup in an article was published in 2002. Posidacea is more common in Arizona and other endemic areas, and Imitis is more common in California. Now, these are tiny spores, 3 to 5 microns. So remember, 1,000 microns in a millimeter, 1,000,000 microns in a meter. It only requires one spore to cause infection. And inside you can put about 14 trillion of these spores in a square inch. So over the years, valley fever has gone through what we call different things. Originally in the San Joaquin Valley, they called it San Joaquin Valley fever because that's where it was first identified. People were moving into the cattle and ranching industry, the farming area, and people were getting sick with this mysterious illness and they didn't know what it was. They called it valley fever, San Joaquin Valley fever. Later, other names were desert rheumatism. Us medical professionals call it toxin for short. The original term was Wernicke-Posidacea disease. They worked with an Argentinian soldier in 1892-1893 time frame in Buenos Aires. And this soldier got sick for several years. He had these waxing and waning symptoms, skin lesions on his face, enlarged lymph nodes. And Alejandro Posadas, who is a student in the lab of Robert Wernicke in Buenos Aires, did some experiments trying to determine what this poor soldier had. And they thought that eventually he had a protozoan, that was their diagnosis, but it was later found out to be the fungus coccidioidomycosis. This was found in Buenos Aires Museum. That's the head of Domingo Espira, and I won't show this to the public, but you're medical people, so it's we kept that in preservation. So I'd like to talk more about the morphology of coccidioides and look a little closer at the saprophytic cycle and the parasitic cycle. So you see the hyphae is these hair-like structures, and a bunch of hyphae is called a mycelium. And on the hyphae, there's alternating live and dead cells here and here. They're barrel-shaped arthrospores, is what they call those. And anything that comes across the desert, whether it's construction, windstorms, hobbies, can create those barrel-shaped spores to be thrusted into the atmosphere, and then eventually an animal or a human may inhale that, and that's when the parasitic cycle occurs. The spores enter the lung, they begin to change shape and enlarge from 3 microns to 75 microns. They form a sphere, and there's internal septations within the sphere. And as one of my colleagues once said, it's sort of like a water balloon getting bigger and bigger and bigger, and then it ruptures, and you have all these endospores, or spores within the sphere that get released into adjacent tissue. The problem with that is these new spores repeat the cycle, and they can spread hematogenously to other parts of the body or via the lymphatics and get disseminated extrapulmonary coccidioidomycosis. Closer look at the disjunctor cell, which basically separates the spores here, looking at the pathological slide. And it's just sort of like a piece of connective cartilaginous type of tissue there. Now here's a slide of the arthrochimia has now been inhaled, and it's been, the sphere has grown. You have thousands of endospores in here, and they're rupturing and infecting adjacent tissue. So how do you get valley fever? You know, one of the things I find with valley fever, there's a lot of buts, well, maybes and ifs in this disease, but you know, the party line is it's not contagious person to person. There's been no reported animal to person transmission. We know lab workers face significant risk for valley fever. There's been accidentally inhalation spores on petri dishes or inoculation causing morbidity and mortality. Animals, particularly dogs in the valley, get valley fever. Farm animals, sea animals. Dr. Michael Sobel here with Sonora Labs reported a case of a cat bite transmission. There's been a case report of maternal fetal transmission. The lab worker is kind of interesting. The first known case to link the fungus coccidioidomycosis to valley fever was a lab worker. His name was Harold Choate, 1928. He worked in a Stanford lab under Ernest Dixon there. Harold was working with a petri dish of spores, accidentally inhaled them, and about 9 days later became very sick. And he had erythema nodosum, rash, bad pneumonia. People thought he was going to die. Fortunately, he did survive this. But Ernest Dixon recognized what Harold Choate's illness was similar to what was occurring in the San Joaquin Valley. And working with the Kern County Health Department and identifying other cases, in 1937, a sentinel paper was published linking the fungus coccidioidomycosis to valley fever. So, how do you define valley fever? The Arizona Department of Public Health has a definition here. It follows the CDC definition. You're just basically looking for positive cultures, molecular evidence, positive blood tests, and it doesn't matter if it's what blood test, it's reportable, whether it's IgM, IgG, what type of test. They're all being reported to the health department as a positive case, which does present some problems because there are false positives and false negatives. Also, on their definition, a skin test conversion from a negative to a positive after the onset of clinical symptoms. So you have to know your patient's skin test status prior to the illness. This is a slide just kind of showing the uptick in cases over the last 12 years. It ends at 2012, but I'm showing the slide for two reasons. In 1997, valley fever became reportable to the Arizona Department of Public Health. And then in 2009, one of the major labs in the valley changed the way they were reporting toxicity to the health department. They were, my understanding is they were only reporting immunodiffusion positive tests. They were later asked to send all positive tests, EIA and immunodiffusion, and you see this huge uptick in cases. So I just put these down year over year, but even after that lab change, you can see that case rates were still surging forward. 2010, 2011 had 16,400 plus cases there, and 2012 still huge numbers of cases compared to what you see in 97, 98. Then just to kind of finish it up to 2015, it dropped down to 7660. In January and February of this year, you see 1098. So this is available on the Public Health Department's website. Anybody can access this information. So getting more to the symptoms of valley fever, it's very much like any other pneumonia, viral or bacterial. Incubation period is somewhere between 7 and 28 days. Many of us who've lived here and worked here years have seen people get off an airplane and get sick in 2 or 3 days, but generally that's the numbers that are thrown out. Common symptoms are fatigue, cough, shortness of breath, pleuritic pain, headaches, weight loss, muscle aches and joint pain associated with valley fever. That's referred to as a desert rheumatism. And then hemoptysis, sometimes from a lung cavity or pneumonia that occurs. With valley fever, the pneumonia, with valley fever, the fatigue seems to be much worse than you see with other pneumonias. And the night sweats, it can be pretty intense when people are getting up at night to change their clothes. So there are some other clues to the diagnosis because it is similar to bacterial or viral infections. We've heard of erythema nodosum and erythema multiforme rashes. We'll see some pictures of these. Toxic erythema is another rash, but it's non-specific for valley fever also. Just some weight loss, anorexia, arthritis, pain, conjunctivitis. The real big ones to focus in on here in the valley is if you have a patient with pneumonia with erythema nodosum, you have to consider valley fever first and foremost. Other things, viral infections, drug reactions can cause erythema nodosum, but cat scratch disease, Behçet's disease, a whole list, pregnancy. But really, if you see a patient with pneumonia in the valley with erythema nodosum, strongly consider toxic pneumonia. It's an immune hypersensitivity reaction to the coccidioides. You have inflamed subcutaneous fat cells. It's most common in the pretibial area, but it can be in other extensor surfaces. Usually regresses in a couple of weeks, but the pigment of your shins can be discolored for quite a while, several weeks. It's actually a good prognostic sign that you're generating an immune response to this illness. Treatment, it's self-limited, but NSAIDs, colchicine, corticosteroids have all been tried. We don't like to use steroids with valley fever, so do your best to avoid it. But here's a good picture of a gentleman that has erythema nodosum. You see the shins, these red, hot, inflamed lesions, pretibial, and then the extensor surfaces of the forearm. There's a little bit more of a milder case, patient with some swelling in her feet and redness of her shins. Same thing, just some very mild erythema nodosum and swollen feet. So what happens with these rashes, people go to the ER and say, look, doc, you gave me the Z-Pack, I got a rash. And guess what? They get blamed to have an allergic reaction, right? How many times have you had the Z-Pack before? Oh, 3 or 4. Now they're having an acute allergic reaction to the Z-Pack or Levaquin, whatever it may be. So often people do get steroids with these rashes because it's misdiagnosed as an allergic reaction to the medication they were given. But erythema multiforme is another rash that you can see with valley fever. It's an immune complex deposition in the microvasculature. It's another hypersensitivity reaction. They get red target crops of skin lesions. Can be itchy, can be a necklace distribution, blister, vesicular, hive-like. can also see it with other diseases, drug reactions, lymphoma. So you can see this gentleman with patches on his back here. This is some pigment changes with the erythema nodosum. This is a patient of mine. He was out of state. The diagnosis was delayed, though it was made before he came to my office, but he had these classic target-shaped lesions on his back, red, itchy. Here's some more of the same thing on his flank also. Toxic erythema is just a red rash associated with fever, can be measles-like, and it's not specific either for valley fever. You can see it here, scaly red. So we touched on valley fever can disseminate, and here's a gentleman that has conjunctivitis, and the lacrimal sac and the caruncle is very inflamed in this area here. Spherules were identified in that area, so we've seen dissemination to the eye. Here's a lady that presented to me last summer. She had pretty classic cocci pneumonia, and I asked her about headaches, and she was complaining that she was having headaches, and eventually she was diagnosed with valley fever meningitis, and then she had a lesion on her finger, and she was actually leaving town, and she lives in Minnesota. We set her up with a Mayo Clinic there, and they ended up having to amputate this finger because of osteomyelitis and valley fever disseminating to her finger. Here's a gentleman referred to from a dermatologist. This gentleman never recalled being sick with valley fever. Remember, the spores go to the lung first, so statistically 60% of people who get valley fever don't even know they've had it. So it's not uncommon for me to get people that had valley fever with lung lesions. And I'm trying to figure out, is it cancer, is it valley fever, is it something else? And so this gentleman works as a security guard. He's in his 40s. And this biopsy proven spherules in his apex of his nose here. But remarkably, with 800 milligrams of fluconazole over about a year, it dramatically improved without surgery. So that was pretty neat. He's doing fine. So he was on medicine, I think, about a year and a half, and he had no other signs of dissemination. This is a gentleman that has rheumatoid arthritis, and his dermatologist biopsied this lesion on his lip in the right lower. It just wasn't getting better, and it showed that it had spherules. We did check his blood tests, and they were strongly positive, and the titers were very high. So this presents a whole big issue with patients on immunosuppressives, rheumatologic patients and GI patients, the Remicade, Humira, Enbrel, etc. And so we had to stop that for about a year, treated him with high-dose antifungals, and his titers and blood tests turned negative, his x-ray cleared up, but he's back on Remicade, and he stays on fluconazole as long as he's on the immunosuppressives. So high-risk groups, there's really nobody at higher risk of getting the infection, as we all live in the endemic area, but those who get it are at higher risk for a worst case. Those would include males, and there's a thought that testosterone could be a factor in that. Elderly, because as we get older, we have more comorbidities, and the immune system's not functioning as well. Of course, steroids and immunosuppressants will affect your cell-mediated immunity. Same with organ transplants and immunocompromised because of the rejection drugs. Infants because they have a developing immunity. And then pregnant women. It's a really dangerous and interesting subject is valley fever in pregnancy. If you get valley fever when you're pregnant, it gets worse potentially with each trimester, and the antifungals, the azoles, are teratogenic in pregnancy. So you got to be real careful when you use them and try not to use them. But the hormones of pregnancy, the estrogens and the progesterones, are trophic, and the spores and spherules can germinate in that environment. Also, in third trimester pregnancy, there's a decreased cellular immunity, which puts them at higher risk. African Americans and Filipinos, if they get valley fever, they're much higher risk to disseminate. And it's not fully understood. There's some genetic HLA issues that have been identified, some ABO blood group characteristics that may be different that puts them at higher risk. but I think it's still being investigated. So we know based on population studies when the skin test was widely available that 3% of the endemic population per year gets valley fever. Inhales the spore, gets in your system, and about 40% of those 3% will get sick, and about 60% may not even know they had it or have minimal symptoms that does not take them to a physician or urgent care. Small percentage are thought to disseminate, 0.5 to 1% is what I usually see. Some numbers are higher.